Hello all, this talk is going to be about nursing care of patients with coronary artery disease. I'm going to start out with heart failure though first and teach you that, and then we'll go into coronary artery disease. All right, so I'm going to talk about heart failure first. I've talked about this in other lectures, but we have seen an increase in heart failure in recent years, and it's because of a good reason. It's because people are living longer. Okay, so now that people are living longer, as we age, our muscles get weaker. So our heart is a muscle, so the heart muscle gets weaker and it can't pump as efficiently as it used to. Okay, and this can put somebody into heart failure, and what that means is the heart gets congested because it can't pump out the blood anymore. Okay. Um, so this, remember I said that this could happen in older adults who get pneumonia, right? That's why we have to be careful about giving them fluids. Even though we want to give them fluids, we have to be careful. We have to engage in cautious hydration. Um, Also, any older adult who gets stressed, like they have a cold or they have infections, okay, they're going to be prone to congestive heart disease or heart failure. Okay, so the two main causes that you really need to know about that cause heart failure are coronary artery disease, and I'm going to talk about that after I talk about heart failure and high blood pressure. So it's really important because when you have high blood pressure, okay, when somebody has high blood pressure, it causes increased resistance in the arteries, and the heart has to pump against that resistance, and the heart gets tired, so they can go into heart failure. Okay, so that's why it's important to take care of yourself. All right, now I'm going to teach you the difference between right versus left heart failure. Okay, all right. So we talked about the pumping action of the heart being inefficient. So when the pumping action of the heart is inefficient, the blood is going to back up. So if somebody has left-sided heart failure, it's going to go to the lungs, okay? If somebody has right-sided heart failure, it's going to go, you're going to see the symptoms, I should say. You'll see symptoms in the rest of the body, okay? So that makes it easy. Now let's talk about these symptoms. So on the left side, remember, if you follow where the left ventricle, it pumps into the lungs, right? So if they're congested, then the patient's going to have signs of left-sided heart failure, which means they're going to develop pulmonary edema, is what that means, okay? So they're going to have pulmonary congestion. They're going to have orthopnea. Orthopnea means that your patient can't lay flat. It's pretty obvious when somebody is hypoxemic and they're having respiratory distress, okay? So they'll have a cough with pink, frothy sputum. Pink, frothy sputum means they have pulmonary edema. They could have cyanosis, but remember what I said about cyanosis in another lecture. It's a late sign. The first sign of hypoxemia or low oxygen is going to be tachycardia, restlessness, and confusion. But tachycardia will be first. All right. Paroxysmal nocturnal dyspnea. Okay, so let me tell you what this is. This is really both a right and a left-sided problem because what happens is after people have left-sided for a while, they end up with right-sided as well, okay? So usually you don't see it in a vacuum. Usually your patient might have both. So on right-sided heart failure, everything backs up from the rest of the body. So the patient is going to have edema, especially like dependent edema, like if you have somebody on bed rest, they'll have edema in their sacrum. They'll have them in their tibia. Liver congestion will happen, and they may get ascites. They get anorexia, GI distress, and weight loss. That's because of all the fluid backing up, okay? So PND, let me get back to that. So when somebody has right-sided heart failure, they're edematous, right? And then they lay down at night, and they get nocturia, okay? And the reason they get nocturia is because when you lie flat, your kidney is better perfused and your edema remobilizes, okay? So it goes back into the vascular space. And so they get nocturia. But also what happens is they may wake up in the middle of the night gasping for breath. Okay, that's what paroxysmal nocturnal dyspnea is. So the fluid from the edema goes back into the system, and they, develop like heart failure, like left-sided heart failure. Okay, I have another picture if this one isn't working for you, so stay tuned. I just want to tell you that weight gain is the most sensitive indicator of fluid overload. Okay, so daily weights are extremely important, and I know you learned in fundamentals, you do it the same time, same scale, same clothes, okay? Keep it consistent. You're going to notify the healthcare provider if the patient gains weight more than 2 pounds in 24 hours or 5 pounds in a week, okay? Those are your ATI parameters. Now, if you like mnemonics, okay, for left-sided heart failure, you can remember forced. So the patient's going to be fatigued because anybody that is not perfusing is going to be fatigued. They're not getting enough oxygen, okay? So they're hypoxemic. Orthopenic, okay, so that means they can't lay flat. They have to sit up. They're going to have rails. Rails is crack rolls. Rails is what I learned in nursing school. And then they changed the name to crackles, okay? They're going to be restlessness, okay, because they're hypoxemic, right? They're not getting enough oxygen. Cyanotic, remember that's late. And confusion. Remember, confusion and restlessness are early signs of hypoxemia. First sign is tachycardia, okay? Extreme weakness, okay? That goes along with fatigue. They're going to be tired. If you don't have oxygen, your body needs oxygen to run efficiently. They're going to be weak, okay? And dyspnea, of course, right? So trouble breathing. On the right side, if they have right-sided failure, remember that goes to the rest of the body, so they'll have bloating, anorexia, cyanosis, cool legs, edematous legs, oliguria. Oliguria means they have a urinary output less than 400 milliliters in 24 hours. So what that means for you is they have a urinary output less than 30 mLs per hour, okay? But then usually when they go to bed, they get nocturia. Nausea, edema, and distended neck veins. So distended neck veins, what we call that is JVD, which you learned in fundamentals when you did your physicals, okay? All right, and this is a picture. Maybe this picture works better for you to learn the difference between left and right-sided heart failure, okay? Now, daily weights, I talked about that. The question to ask somebody with right-sided heart failure is, are your clothes tight? Okay, because they get edema throughout the day, and throughout the day, their clothes may feel more tight on them. And then for left-sided heart failure, you want to ask people how many pillows they sleep with. That's how you would ask somebody with heart failure, because it's going to wax and wane. They're not always going to be so critical. So they do have periods where they feel better. Okay. So that's the difference between right and left. So get that down. Now, your goals of treatment, obviously, you want to reduce the demand for oxygen. So that means people need to rest, okay, if they're having an episode of CHF, okay? Need to rest. You need to reduce the workload of the heart. That means they need to rest, and you need to put oxygen on them. Remember what I said, head of bed first, get that up, get the oxygen on them after, okay? We need to strengthen the heart's pumping action, and you do that with medication like digoxin, can make the heart pump more efficiently, okay? Dopamine, dobutamine, I don't know if you've learned about those medications in pharmacology. I'm just giving you some examples of what would help the heart pump better, okay? Relieve venous congestion in the lungs, definitely, and minimize sodium and water retention in the tissues. And we're going to talk about how to do some of that too, okay? Now, if you like mnemonics, here's your nursing management of heart failure, okay? Unload fast is what you can remember. Upright position, remember what I said, get the head of bed up. Give them nitrates. Nitrates are vasodilators. If you can vasodilate the veins, then all the fluid can hang out in the veins instead of in the heart. Lasix, which is really furosemide, and as you know, that's a diuretic, okay? So that would be very good to give somebody with heart failure. Oxygen, because we want to decrease the workload of the heart, okay? Lets the heart rest. ACE inhibitors, again, so the heart doesn't have to pump so hard. So the pump, it helps the heart rest, okay? Digoxin helps the contraction of the heart be stronger, okay? It makes for stronger contraction. We want to decrease fluids for somebody that's having an episode of heart failure. Decrease afterload. You don't really have to understand that. ACE inhibitors help decrease afterload. How's that? Sodium restriction, definitely. And they need tests, okay? So you're going to monitor the DIG level because there's a narrow therapeutic range, ABGs, potassium, because they're on furosemide, okay? And plus, you always want to monitor the potassium in people that are taking digoxin, because if they get a low potassium, digoxin can become very toxic to them. All right, again, nursing management, daily weights is the best way to track if somebody is gaining fluid. Eyes and nose, oxygen, fluid restriction, restricts sodium. We're so mean, right? Heart healthy diet and eating fatty fish. This is part of I'm just giving you an example. This is part of a heart healthy diet. So we like people that have problems with their hearts, or they have a heart attack, or they have hypertension, to eat fatty fish 2 to 3 times a week because it has those omegas they need. All right, this is a cute little picture. Brain natriuretic peptide. Now, this is actually a laboratory value, and if it's greater than 100, it means the patient has heart failure, okay? So if somebody had problems with their lungs, like the provider didn't know if they had cardiac pulmonary edema or non-cardiac pulmonary edema, they would do a BNP, okay? Brain natriuretic peptide. It's done for heart failure. Okay, coronary, now we're going to switch gears and go into coronary artery disease, okay? So it's narrowing of the coronary arteries. Now your coronary arteries are tiny compared to the other arteries in your body. So this is why, coronary artery disease shows up usually before people have peripheral vascular disease. But, it results in decreased oxygen to the heart, and the patient's going to have ischemic pain, or they could develop a myocardial infarction. So ischemic pain, we call that angina pectoris. It means pain in the chest. And myocardial infarction means that the cells are dying. Okay, so they're necrotic and they've died. We're going to go into more depth than that, so don't worry about that just yet. All right, usually it's caused from arteriosclerosis. You're high risk if you have a family member who's had a heart attack or coronary artery disease, especially if they died of coronary artery disease. Like if somebody died of a sudden heart attack in your family, you would be at risk. Postmenopausal women who take hormone replacement therapy are at risk. So before menopause, women are protected with the estrogen in their body from heart disease. But after they go through menopause, they no longer have that protection, and taking exogenous estrogen does not help, okay? So women really need to take care of themselves as well. All right, nursing management with somebody has coronary artery disease, okay? So if they have angina, if they have an MI, if they have unstable angina, okay, they need to follow this management, okay? So they need to engage in a healthy lifestyle. They need to have a diet low in saturated fat. We'll talk a little bit more about that. They should see a dietitian. Encourage them to exercise, and they need to maintain a normal weight. Okay, so this is good advice for everybody, not just coronary artery disease. All right, so you want to tell them to avoid all fatty foods, trim the fat from meats, and stick to 3-ounce portions, which is about as big as your palm of your hand or a deck of cards, okay? They need to eat fish with omega-3 fatty acids 2 times per week. So that would be like fatty fish, like salmon. Salmon's a fatty fish, mackerel's a fatty fish. Egg whites or egg beaters, so instead of whole eggs, switch to egg whites. They should eliminate commercial baked goods, so no cakes or cookies. They should use unsaturated fats for baking, so like olive oil. And then avoid margarine. Small amounts of cheese only, non-dairy fat, and eat more fiber. So that's basically the gist of it, okay? Now, some patients do take supplements for their heart. So, like, they'll take garlic. Now, remember, that can make them bleed. So, you have to ask patients if they're taking supplements. Take omega-3 fatty acids. We just talked about you get those in fish as well. Oatmeal, patients like to eat that to try to lower their cholesterol. And whole grains are good too. Rice yeast, this acts like a statin actually, and you take it with CoQ. So patients sometimes do that because they don't want to go on, medication. They think it's healthier, but you do need to know if they're on any of these, okay? Fiber is always good. Soy is another thing people take. And I talked about coenzyme Q. They would take that with the red rice yeast. All right. Now, people with coronary artery disease, if they've had an MI, they have angina, they're going to need to be on lipid lower medications, okay, when their lifestyle changes fail. So if they've, gone on a diet, they're exercising, they lost the weight, they look good, and their cholesterol's still high, they're going to need to go on a statin, okay? So they need blood work initially, okay, because it can cause like liver toxicity. So you have to get a baseline. They need to report muscle weakness right away because it can give them, it can help, it can break down their muscle, okay? And then no grapefruit juice because it interferes with the absorption. All right, now the first condition I'm going to talk about related to coronary artery disease is angina, okay? Now, angina just means there's a decrease in blood flow, okay? So remember, low, slow blood flow, okay? So the tissue can get ischemic, and that can be painful. Heart attack, on the other hand, there's a full thrombus here, if you look at this picture, and it totally blocks the blood flow. So the muscle gets necrotic and dies in an MI. So angina means injury and ischemia. Heart attack means cell death. There's three types of angina: stable or exertional angina, which is triggered by activity or stress. So let me explain what this is because it's important that you know the difference, okay? So this happens in people, they know they have it, it's stable, they can predict when they're going to get the pain, right? Because it's exertional. When they get stressed, if they eat a big meal, they know they're going to get the pain, okay? Usually it's always in some stressful moment, okay? Triggered by activity. Variant, that happens at rest. I'm not really going to talk about that because it's not that common. I want you to know the difference between stable and unstable, okay? So unstable angina, this happens at rest or sleep. Does not respond to nitroglycerin usually, okay? And it's unpredictable. Now, somebody with stable angina can then develop unstable angina. Unstable angina presents like a myocardial infarction, okay? And it's very important that if somebody has angina that's unrelieved with nitroglycerin, they get to the hospital right away because they could be having an MI, okay? And I'm going to go in more detail with that in a little bit. So with chronic stable angina, the patient's going to get dull pressure or an ache under their sternum. It can radiate, okay? They sometimes might feel like they're suffocating. They have shoulder between their brain blades. Women may not have chest pain. They may have just tenderness, and patients may think they're having indigestion. So, but it is relieved with nitroglycerin. That's kind of the hallmark of chronic stable angina, okay? It's relieved by nitroglycerin. So nitroglycerin, there's some nursing implications you need to know. It's taken sublingually, okay? So it comes in like a dark, small bottle, and the patients need to keep it in the original bottle in a safe place on themselves. Like if they're going out, they need to have their nitro with them at all times, okay? They need to check the expiration dates. They can, if they need to, say their mouth is dry, they can take a little sip of water before they put it on the pill under their tongue, just to wet their whistle a little bit because it helps to absorb it better, okay? If they're having chest pain and they take a nitroglycerin, they need to lie down. If there's no relief with the first dose, they need to call 911. Take another dose in 5 minutes. They can take up to 3 doses every 5 minutes, but if there's no relief after the first one, they call 911. Because what did I just tell you? Somebody that has chest pain that's unrelieved with nitroglycerin, if it's coming from their heart, right? That means they now have unstable angina and they could be having an MI. So they need to get to the hospital. That's very important, okay? Administer oxygen if it's available and monitor their blood pressure. Now, this is extremely important. I'm going to tell you a story. Nitroglycerin combined with erectile dysfunction medication, okay, those are your film medications like sildenafil, can result in an unsafe drop in blood pressure, okay? So you're going to need to ask patients if they're, it's usually men that are taking this. You're going to have to ask them if they're taking these medications, and you might have to ask it a couple different ways and explain why it's important in a non-judgment way that you know, okay? I mean, I'm going to tell you one story. When I managed a pre-op clinic, I did an EKG on a gentleman, and then I had him get dressed. I got all his information from surgery. I did his med reconciliation. Asked him if he took any PR meds. Nope, he didn't take any medication. All right, so I look at his EKG and it was abnormal. So I was asking him, I told him his EKG was abnormal, and I asked him if he had, any history. And he said, well, let me ask you something. If I took Viagra 2 days ago, would that affect my heart today? And I said, no. And he said, forget I said it. See, he's embarrassed, but that's the wrong attitude. I mean, so I explained to him, the importance of telling providers that he is on this medication, because you can kill somebody by giving them nitroglycerin if they're on that medication. All right, client teaching with somebody with angina, okay? It's chronic stable angina, okay? So they probably already know they need to avoid eating heavy meals. When you eat, the blood in your body is going to be shunted to your gut to help you digest the food, okay? So they have to avoid eating heavy meals because all the blood's going to go to their small intestine, right, to try to digest that food, and they could get angina because the blood is not going to be going to the heart, okay? They need to avoid physical activity after eating for 1 hour, okay? So no activity after eating for 1 hour for the same reason. The blood is going to the gut, so it's working on helping you digest food, okay? They can take a nitroglycerin before physical activity. Now, I just told you, right, on the previous slide, they need to lie down. That patient had chest pain. This patient I'm talking about doesn't have chest pain, but they can take a nitroglycerin. If they know every day they walk up the flight of stairs and that gives them chest pain, okay, then they can take a nitro before that to prevent them from getting chest pain, okay? They're not having chest pain, but they can take it to prevent it. And the other example, that patient was having chest pain, they need to lie down. They need to take their nitro and lie down, okay? Avoid exposure to cold. The reason for that is when you're cold, it constricts your blood vessels. Your heart has the blood vessels that bring the blood to the heart, okay? Stop smoking. Everybody needs to stop smoking. It's a common theme through all my lectures. They need to adopt a graduated exercise program. All that means is they need to start exercising, and if they haven't exercised before, it needs to be graduated. I mean, they're going to start off slow and work their way up, right? Because this is what happens sometimes when people get sick, right? They all of a sudden, they get gung-ho and they overdo it. And I bet you've done that before too. Like at the first of the year, I'm going to go to the gym today and work out, and then you can't walk for a week, okay? So they need to adopt a graduated exercise program. They need to get plenty of rest. They need to rise slowly because they're on usually medications like nitrates, okay? Because there are some long-acting nitrates they can take as well. And as you know, when people take medications that cause vasodilation, they can get orthostatic hypotension when they rise. All right, so acute coronary syndrome. there are three conditions that make up acute coronary syndrome. The first one is unstable angina. The second one is a non-STEMI. That means non-ST elevated myocardial infarction. And the third one is a STEMI. That means ST elevated myocardial infarction. Okay? Now, when they come to the ED with chest pain, you can't tell the difference between them until you get an EKG. And then when you get an EKG, which you get within 10 minutes, you can see if it's a STEMI, if the ST segment is elevated. Remember in that other lecture, I showed you the ST segment, high di MI. Okay, that's a STEMI. Now, non-STEMI, okay, will not have ST elevated. It's not an ST elevation MI, okay? It's going to actually have depression, okay? ST depression. And then unstable angina, okay? This is also going to have ST depression, okay? Now, how you tell the difference between a non-STEMI and a STEMI is because a STEMI has the ST elevation, okay? How you tell the difference between non-STEMI and STEMI and unstable angina is non-STEMI and STEMI MI have positive troponins. Okay, and I'm going to talk about that in a little bit. But all three present with chest pain unrelieved by nitroglycerin or a change in position or respirations. Okay, so in other words, the pain doesn't change when they breathe, right? Because remember I talked about pleuritic chest pain. Okay, so if the pain doesn't change when they breathe, it's probably cardiac, okay? If it doesn't change when they change positions, it's probably cardiac, okay? If they have positive troponins, they're having an MI. If they have ST elevation, it's a STEMI. If they have ST depression with positive troponins, it's a non-STEMI, okay? So an MI is usually caused by a thrombus, an embolus that breaks off and ruptures, a ruptured atherosclerotic plaque. Okay, so it decreases or occludes the coronary blood flow. If they're having an MI, the tissue, the muscle, is going to become necrotic, and that means the cells have died. Now, there's a problem with an MI because the muscle cells have died. Muscle cells that are dead do not contract or conduct electricity. Okay, I'll say it again. In an MI, the muscle cells become necrotic. They die. Dead muscle tissue does not contract or conduct electricity. So what that means is the patient could have dysrhythmias and they could go into heart failure because the heart cannot pump, and they can also go into shock, cardiogenic shock. Okay? All right. Sudden death will occur if it's an extremely large MI. Okay, now the classic signs and symptoms is somebody has a myocardial infarction. Now you have to realize somebody having an MI is having a lot of pain in their chest, and that stimulates the sympathetic nervous system. Okay, so they're going to be tachycardic. They're going to be diaphoretic, right? Because when your sympathetic nervous system is activated, you start sweating, you get tachycardia. They're going to have cool, clammy skin, which is not good at any age, right? It always means something bad. The pain with radiation in their chest is not relieved by nitroglycerin. It's not relieved by position changes. And it doesn't change when they breathe. Okay? The pain is described as tight, squeezing, or crushing. The patient can look ashen. Okay? Now, some people have what's called silent MIs, like diabetics, because they have neuropathy and the nerve endings aren't working. Okay? So that happens. You might see it on an EKG. Okay? Or they might go into AFib or something. Older adults, they could have an MI, right? But they don't complain of chest pain, but they could get confused and they could develop heart failure, and that's how you would know. That's how you could predict. Women have silent MIs. What happens with women is they present a little differently for men, and for many years, women weren't taken seriously. And I think now they are taken seriously a little bit more. But women have atypical symptoms. Like what the tip off for women is they get extreme fatigue. Like a woman will be like, I don't know what's wrong with me. I haven't been sick. Just all of a sudden, I can't do what I used to do. It's extreme fatigue that they, get. Associated symptoms, like when somebody has chronic stable angina, they don't get nausea and vomiting, they don't get sweating, they don't get cool clammy skin. Okay, somebody with chest pain starts getting nausea and vomiting, you better be thinking MI. Okay, the heart rate could be irregular and fast, or it could be slow. Okay, all right, so your goal if somebody comes into the ED is to get that ECG within 10 minutes. Time is muscle. That means we got to get them diagnosed quick so we know how to treat them, okay? All right, I'm going to talk a little bit more about that in a bit. Okay, aspirin on arrival. If they didn't get an aspirin on their way in by the EMTs, all right, you have them chew 325 milligram tablet, or they can chew 4 baby aspirin. Okay, then after that, they get a daily dose of 81 milligrams. That's the cardiac dose. Aspirin is a very strong antiplatelet medication, so it keeps the platelets from clumping up in their narrow coronary arteries. Okay, so that's very important. The labs, you're going to get a bunch of labs, but the troponin is what you're looking for. Okay, troponin is specific for cardiac. So if they have elevated troponin levels, they've had a myocardial infarction. Okay. Not unstable angina. Unstable angina presents the same way, but they have negative troponin. All right. Increased WBCs in ESR because of inflammation. Okay, non-infection, inflammation. They'll have a temperature because of inflammation. And for STEMI MI, they go to the cath lab within 90 minutes. That's a metric put out by the Joint Commission. And that's because patients have better outcomes if they can get to the cath lab within 90 minutes. And I'm going to explain why that's important. I just want to point out another lab, a CKMB. The CKMB, this indicates there's damage to the heart muscle, okay? So those will be elevated too. It's just important to know that if somebody has an elevated troponin level, it means they have an MI. All right, so MI is treated with MONA-B therapy, okay, which stands for morphine. You got to get the morphine for that chest pain because the chest pain is not going to be relieved with nitroglycerin. And morphine, you get rid of that pain. It's going to decrease the sympathetic outflow, and you got to get that heart rate down because when somebody has tachycardia, it eats up a lot of oxygen, right? So we got to get the heart rate down. Oxygen to prevent more damage. Nitroglycerin. Okay, so like I just told you, nitroglycerin wasn't effective for the chest pain, right? Okay, so let me explain why nitroglycerin is given. Okay, so it's given so that it vasodilates the coronary arteries and all the vasculature near where the MI is. Okay, it's so that it dilates the vasculature deep inside the heart so the blood can be brought to that area, okay? Aspirin is given because it's an antiplatelet and it helps decrease the clotting in the coronary arteries. A beta blocker, okay? Remember I told you when they're in pain, they have sympathetic outflow and tachycardia. We don't want patients that are having an MI to have tachycardia, okay? So we would give a beta blocker for that. Okay, as long as their blood pressure is okay, we give a beta blocker. And they need to go to critical care. And the reason they need to go to critical care for at least 24 hours, sometimes they go for longer, is they're going to be on bed rest, first of all, which is not the reason they go. But they go there because 98% of the people that have an MI can have dysrhythmias within 4 hours after, up to 24 hours. So they are monitored carefully, okay? And we do give like sedatives when they come to the coronary care unit. All right, let's just kind of compare and contrast, okay? So angina with MI. Now MI, really this should say coronary, acute coronary syndrome. So MI includes STEMI, non-STEMI, and also, although not an MI, unstable angina is within the category of acute coronary syndrome. Remember, it presents the same way. It happens when people are sleeping. Okay, so it presents the same way. It's unrelieved, the pain's unrelieved, but nitroglycerin. Okay, so angina, this is precipitated by exertion or stress. Okay, coronary artery syndrome or MI and unstable angina. This usually happens in the morning after waking up, or it happens during sleep, so not when they're exerting energy. Angina is relieved by rest or nitroglycerin. MI and unstable angina are relieved by opiates only. Okay? Angina lasts less than 15 minutes. Acute coronary syndrome, MI, and unstable angina lasts more than 15 minutes. Okay? Angina does not have any associated signs. MI and unstable angina have a lot of associated signs, okay? Diaphoresis, nausea, vomiting, dyspnea, anxiety. Angina does have ST changes, but they're transient, meaning they go back to normal. MI does have ST depression and T wave changes, or it could have ST elevation, okay? Angina usually treated, relieved with nitroglycerin. MI and unstable angina is going to be treated with aspirin, right? So 325 for the initial one, they need to chew it. And then they go to a daily baby aspirin, 81 milligrams per day, okay? They're going to be on a beta blocker. Possibly an ACE inhibitor if there was a lot of damage done, not always. And they may, in ARBs for people that can't tolerate ACE inhibitors, okay? All right. So that's the difference between angina and MI. Okay, now I told you the goal is to get them to the cardiac cath lab. Okay, so for a percutaneous transluminal coronary angioplasty or PTCA. Okay, so what they do is they could go in through the groin. Now I worked in cardiac cath lab and we went through the groin, but then I floated to another one and they went through the radial artery and it was fabulous. And the reason it's fabulous is because when they go through the groin, the patient has to stay on bed rest after, and it's always a challenge when they have to pee because we give them fluid before they come, especially like if they're a diabetic. All right, because you have to hold the metformin because this has dye. They get dye when they're in the cath lab. The dye that they get is damaging to the kidneys, and then if they take metformin, that makes it even more damaging to the kidneys. So we hold metformin. Now, in this case, if your patient comes in with an MI and they took their metformin, the physician's going to do take them to the cath lab. Okay, he's going to weigh the risks and benefits, but they'll need IV fluids. Okay, so they put a catheter in the groin and they thread it up through the arteries into the heart. Okay, and then you see this balloon, so they put it in. There's a stent around it. Okay, they kind of open up the balloon, kind of, mash whatever is broken there, occluding the heart, and then they leave that stent in so it keeps it open, keeps the coronary artery open, okay? They will get aspirin or clopidogrel. Clopidogrel is another antiplatelet medication for at least 1 year, okay? Don't worry about the glycoprotein inhibitors. Frequent vital signs after, so and groin checks, and check their pulses, check if it's pale, paralysis, paresthesias, check if it has coolness to it. So you're going to check the pulses. That's kind of a priority, okay? All right, well, that does it for acute coronary syndrome, acute coronary artery disease, and heart failure. Please email me if you have any questions. I'd be happy to help you.